Hi, my name is Rahul Sakuja. I'm one of the interventional cardiologists who works on complex coronary, interventional vascular medicine, and structural heart interventions at Mass General Hospital. I want to thank the organizers, Drs. Weiner, Drs. Rosenzweig, Dr. Hutter, for the opportunity to speak again at this course. I wish we were all in person. I find it really rewarding to interact and answer questions and learn from all the things that we're all thinking about together. And I look forward to the chance to have this meeting in person again, hopefully sometime soon. Today, I'm going to be talking about coronary artery disease, and we'll specifically focus on medicate, dilate, or operate. This is my disclosures here today, and happy to entertain any others that people may have. But most importantly, I am an interventional cardiologist, so I do come to this with a certain bias that I realize. But hopefully we'll talk about these data in a way that can represent various points of view and represent kind of the data as they are in a holistic perspective, as well as giving you a little bit of my perspective as well. So again, we'll talk a little bit about medications. We'll talk about percutaneous coronary interventions. And for the sake of today's talk, we probably won't spend much time talking about new surgical techniques or the data around surgical techniques, although happy to elaborate on this if people think that that would be of interest in your comments for the future. So just to start with the take-home points in case you get tired while we're watching this, medical therapy remains the cornerstone of CAD treatment. And I think some of the data that we have garnered in the recent year also support this statement. Assessing ischemic burden may not be relevant to revascularization. And I think this turns the field a little bit on its head from data that we've had for actually about a decade now that's been reinforced. And what we may be turning towards, which in some ways feels a little contradictory or counterintuitive, is that treating the ischemic lesion may actually be what provides the most significant benefit to a patient versus treating the ischemic patient, if you will. And PCI has improved with newer stents, newer DAPT techniques or strategies, and newer PCI techniques that allow us to do a lot more than we used to do in safer situations with less consequence. DAPT duration may be tailored in the near future based on ischemic risks versus bleeding risks, and there are more and more data coming out that maybe we tailor the duration of DAPT dependent on the patient's ischemic burden versus bleeding risk. Complete revascularization improves outcome. Diabetic patients with multivessel disease, Cabg has been shown to be superior to PCI. We won't talk about the FREEDOM study here, but the data are fairly definitive on this. And I would say, unlike that statement, I will say for left main disease, PCI may actually be a reasonable option. In the long run, bypass surgery for ischemic cardiomyopathy is preferable to medical therapy. And lastly, working together via coronary artery disease heart teams can optimize decision-making regarding medical therapy versus percutaneous coronary intervention versus coronary artery bypass grafting. So to start, we're going to start with medication. We're going to start talking a little bit about optimal medical therapy. What does it mean? What are the treatment goals? What are the treatment modalities? What are the indications that we have for performing coronary angiography in the first place? And then we'll spend a little bit of time on revascularization. So dilate or operate, what are the guidelines for revascularization? What are the studies of revascularization versus optimal medical therapy? And we'll focus more so on the ischemia trial, which gives us the kind of most up-to-date data over the last year or two. We'll talk a little bit about PCI versus Cabg if we have time, focusing on diabetics, multivessel disease, and left main disease, and the importance of complete revascularization. So starting with medication. What is optimal medical therapy and what are the treatment goals? So the treatment goals are principally avoiding disease progression. So we want to make people live longer and improving patients' health status. So we want to make patients feel better. So from the disease progression standpoint, we want to avoid ACS events. We want to improve mortality. We want to reduce hard endpoints like heart failure. From the health status point of view, we want to reduce symptom burden. We want people to be able to do more, improve more quality of life, have more functional status with fewer symptom burden and limitation. And, when we think about our patients, it really matters that we're thinking about things from a twofold perspective. So how do we go about achieving these goals? Well, we manage risk factors, such as those included here. We optimize guideline-directed medical therapy, and we can consider in the appropriate patient revascularization. And we know that if patients comply with guideline-directed medical therapy, patients do better. They live longer and they live better, which are our two goals that we just talked about. But that's the elephant in the room. What is guideline-directed medical therapy for these patients? So for most treaters, guideline-directed medical therapy focuses on treatment of ischemic symptoms or angina. And so we follow these class 1 recommendations, starting with sublingual nitroglycerin and so on and so forth. And it's suggested that when all else fails, then we consider revascularization. And note that at no point is there a mention of diagnostic coronary angiography as a diagnostic tool to understand what the burden of disease is in these patients. And I think we should realize that while we focus on angina as a hard endpoint or as a treatment endpoint, and for some people that's their most important endpoint because that's their manifestation of heart disease, the actual quote hard endpoint benefit, which is what we talk about when it comes to risk factor modification, we don't get from these anti-anginal treatments. So most of what we're achieving with these additional medications that we talked about in the last slide are symptom benefit or making people's lives better, which is the second goal. But when we actually are talking about hard endpoints in terms of death, in terms of heart attack, those hard endpoints, the majority of that benefit that we're getting is not from the anti-anginal, anti-ischemic therapies per se. It's mainly limited to the fundamentals, which are aspirin, statins, and lifestyle modification. And so when we talk about beta blockers, when we talk about nitrates, when we talk about calcium channel blockers, when we talk about things like ranolazine, remember, we're talking about symptom benefit predominantly and not these hard endpoints. So when we're comparing medical therapy versus revascularization, it's on a fundamental baseline of aspirin, statins, and lifestyle modification. So it makes sense when we go through these data that revascularization may not have a significant impact on those hard endpoints. But relevant to all these other medications, revascularization, the wheelhouse or the main place where we may see a benefit for revascularization is likely going to be in this lifestyle category or that one output, which, as I said, that endpoint may be equivalent for certain patients. So with that said, what are the indications for coronary angiography? This is different than the indications for revascularization, remember. And, Dr. Hutter always taught me a coronary angiogram is a diagnostic tool, so they're not equivalent. So with that said, what are the guidelines for invasive testing? Well, from the data from the ischemia trial, there's definitely an emerging role for coronary CT angiography, though one has to understand the predictive nature of CT angiography. But the goal for coronary angiography, whether it's CT or invasive angiography, is the diagnosis of coronary artery disease in patients with suspected ischemic heart disease or stable ischemic heart disease. In addition, it's for a risk assessment after the initial workup for non-invasive testing. And this initial risk assessment may not only be for MI, it may also be for sudden cardiac death, and maybe for heart failure. So it's a risk assessment tool and as well as a diagnostic tool. So coronary angiography should be considered in patients with stable ischemic heart disease whose clinical characteristics or results of non-invasive testing indicate a high likelihood of severe ischemic heart disease when the benefits are deemed to exceed the risk. So remember, we talk a little bit about these indications in the context of appropriateness criteria. So whether it's clinically relevant is slightly different than whether it's appropriate per se, but the appropriateness criteria suggest that these are the indications. So traditionally, in patients who have ACS, it's indicated. When you look at this slide, it's a very busy slide, but what you'll see here at the top is that patients who have STEMI, non-STEMI, cardiogenic shock due to ACS, a new wall motion abnormality in the setting of ACS. Any of these ACS populations have a class 1 indication for coronary angiography. Patients who have a high pretest probability and are symptomatic, another indication for coronary angiography. And finally, remember, we're talking about both diagnosis as well as risk stratification. So this last, kind of bundle of indications, don't worry about the specifics here, but basically who cares how you actually assess the patient, whether it's EKG stress testing, whether it's stress testing with imaging, whether it's echocardiography, whether it's coronary CTA. In all cases, patients who have a significant burden of ischemia, they may benefit from coronary angiography as a diagnostic tool to understand what their risks are. And these are just some of those, we talk about what are those large ischemic burdens. This is the ischemic burden by treadmill testing. This is what it would be by imaging. This is what it would be by echocardiography. This is what it would be by coronary CT. So independent of the modality, if you have a large territory at risk, you can imagine coronary angiography is indicated. It's also indicated in medically managing patients who are at intermediate risk, or who even may be at high risk, but don't have any kind of changing or worsening or uncontrolled symptoms. In patients who are post-revascularization, have recurrent symptoms, oftentimes we tend to go right back to coronary angiography to be definitive. In people who have high risk arrhythmias, such as resuscitated cardiac arrest, VF, sustained VT, and trying to diagnose the etiology for cardiomyopathies, as well as assessing concomitant coronary disease in patients who have valvular disease, in particular when we're talking about surgical disease and they may need concomitant revascularization. So those are the indications for coronary disease. That's when it's appropriate to think about a coronary angiography. What about revascularization? So let's talk a little bit about the guidelines for revascularization here. Let's talk about what optimal medical therapy is. Let's talk about the role of ischemic testing. We'll talk about what it means to optimize percutaneous coronary interventions in the current era. And if we have time, we'll go into a little bit of PCI versus Cabg or special topics in Cabg. And otherwise, we'll leave that for a lecture depending on people's preferences at a later time. So guidelines, let's talk about guidelines. This is for revascularization, not necessarily for diagnostic coronary angiography. So we see here that the class 1A guideline for Cabg or PCI, so revascularization with Cabg or PCI, is to improve symptoms in patients with one or more significant, which is defined by greater than 70%, coronary artery stenosis, which is amenable to revascularization and at an unacceptable level of angina despite GDMT. So Cabg or PCI to improve symptoms is beneficial in patients with one or more significant coronary artery stenosis amenable to revascularization and at an unacceptable level of angina despite GDMT. Class 2A indication would be Cabg or PCI to improve symptoms is reasonable in patients with one or more significant coronary artery stenosis and an unacceptable angina level for whom GDMT cannot be implemented because of medication contraindications, adverse effects, or patient preferences. So underlying both of these recommendations is that patients should be on GDMT or at least optimized to the ability that they can tolerate. So let's talk about strategies for revascularization in stable ischemic heart disease. So these aren't the ACS populations that you've heard about in other talks. We're talking about patients with stable ischemic heart disease, which are the majority of patients that we see in our cardiovascular clinics or primary care clinics. So this harkens back to an oldie but a goodie. This is the Courage trial, which is from April of 2007, seems like eons ago now. And this was a major study that flipped the field on its head and engendered a lot of debate amongst people from different aspects of cardiology, medicine. And this is what established optimal medical therapy as an initial effective treatment for stable coronary disease. And it followed patients for about 2.5 to 7 years with a median of 4.6 years. They randomized people to PCI plus optimal medical therapy versus optimal medical therapy. I think the most important part of this slide is understanding that the exclusion criteria, include patients who have CCS or Canadian classification of angina, class 4 angina, So a significant burden of angina at rest. They have markedly positive treadmill tests. They have low EF, less than 30%. They have refractory heart failure. They have significant left main disease, or they've been revascularized in the recent past. Or finally, patients who weren't suitable for PCI weren't included. So understanding the exclusion criteria for a study like this is crucial, because understanding if your patients are appropriate to this study is very important before you send them down a pathway of optimal medical therapy. So we all know the results of this study. Optimal medical therapy shown here, PCI with OMT almost indistinguishable from optimal medical therapy, which suggests that it is safe to maintain people with stable ischemic heart disease without those exclusion criteria on medical therapy. As we said at the beginning of the talk, medical therapy works here. So the one place where it seems that revascularization may have a benefit, and it makes sense from when we talked about what are we comparing when we're comparing revascularization to medicines. We're not talking about hard endpoints, which are taken away with aspirin and statins and lifestyle modification. We're talking about mainly taking away angina or improving patients' lifestyle. So it makes sense that in these studies, both in the COURAGE study as well as in meta-analyses of similar studies, including COURAGE, that revascularization actually is favored when we're talking about improving lifestyle or reducing angina burden. So it may not reduce the quote unquote hard endpoints relative to medicine. So medicines are safe. You're not going to be at fear that people will have higher MI rates and stable ischemic heart disease. They're not going to die more frequently, but revascularization will get rid of angina in those patients faster. So there were definitely some limitations. There was a significant crossover in this group, which would make the differences, of course, come towards the null. And it's very hard to achieve the levels of OMT. I mean, we shouldn't be complaining about that. We should be striving for it. And if you have an office practice that's set up, and we all should have this to enforce the level of optimal medical therapy, I think we'd all be better for it. But it is very challenging to get them on the medical therapy that they were on in COURAGE. And so remember, these results may not be generalizable to the population. Again, on the PCI side of things, we said PCI in 2020, 2021 is not the same as it was in 2007, 2009. And the role of ischemic kind of evaluation has, I would say, evolved since then, and we'll talk a little bit more about ischemic evaluation here as well as the ischemia study. So in terms of ischemic burden, in COURAGE, this was all comers. Some people didn't have demonstration of ischemia. Some people had no demonstration of ischemia. Some people didn't have angina. Some people had a burden of angina. And they were all basically kind of clumped into this study and then tried to tease out on the back end. But what we do see here are that there are data to suggest that patients who have a higher burden of ischemia on stress testing have a significantly higher mortality. So after the COURAGE study, one of the questions came up to say, well, what if we only look at those patients who we think benefit, who have the highest ischemic burden on stress testing? And that's been shown by different types of revascularization that once you get a greater ischemic burden that's assessed by stress testing, that it may be that revascularization has a more significant benefit than medical therapy. And this has been shown by MIBI, this has been shown by PET, and the crossover point may be different by MIBI, where, for example, we may look at a percentage of 10 to 20% by MIBI. By PET, which is much more sensitive, it looks like that crossover between medical therapy to revascularization may happen at an ischemic burden of 5% even, as suggested in this study. So ultimately, not only does the amount of ischemia matter, but the amount by which you can reduce ischemia also makes sense, likely matters. So if you can reduce ischemia more with revascularization than you can with medical therapy, maybe that will engender more significant endpoints. So interesting that the study was, over 15 years ago, and we still have some of these questions that are left to answer. And that's where the ischemia trial, a more contemporary study, which took a long time to enroll, but we're really happy to have these results finally, will start to answer some of these questions importantly. It already has answered some of them, but some of these questions, which we'll talk about, still linger. So the ischemia study was, again, in the stable ischemic heart disease patient. And the difference between this and COURAGE was that in the ischemia study, it included patients who had moderate or severe ischemia, which was determined by the site, and then adjudicated by a core lab. So rather than all comers, we tried to look at moderate or severe ischemia. Now, the way in which we looked at moderate to severe ischemia was initially only looking with treadmill testing, ultimately added imaging, and most all imaging was done by MIBI, not by PET. But again, we have to do these studies within the context of what we have available and what's commonly used. So once patients qualified by their type of ischemia, so these are not ACS patients, they, for the most part, would undergo a coronary CT. And if the core lab deemed them eligible, then they would be randomized for patients. So all of these patients, or the majority of these patients, had coronary CTs before they were randomized. And then they were randomized to an invasive strategy of optimal medical therapy plus cath with, quote, optimal revascularization, versus a quote unquote conservative strategy, which was optimal medical therapy. And only if that failed, then cath was reserved for those patients. So there were two branches, one which was done in CKD patients, the other was done in non-CKD patients to understand what the role of CKD was in these patients. In the overarching trial, there were about 8,500 patients that were enrolled. About 5,200 of them were randomized. Again, stable ischemic heart disease with moderate to severe ischemia. The majority of them, about 75% of them, had a CTA, and they were randomized into optimal medical therapy versus optimal medical therapy plus PCI. The median follow-up was about 3.2 years, and the ultimate endpoint was a multi-composite endpoint of CV death, MI, hospitalization. And because it was slow to enroll, they added endpoints to that multi-composite of unstable angina, heart failure, and resuscitated cardiac arrest through the study. So very, very busy slide of the kind of table one or characteristics of these patients. You know, most important to realize is that this age group is a younger age group of patients, so 58 to 70. They're mostly male. There was a significant, actually, Asian population, interestingly, so a little bit generalizable to Asian. And it's mostly East Asia because they had to include China to be able to get to their enrollment goal. Diabetes at 41%. There was severe ischemia in about 45%, but recognize that there was no or mild ischemia in up to about 14%. So as we said, a very significant number of patients, their ischemia burden was tested by exercise treadmill tests without imaging. And interestingly, there were about 45 patients that had 3-vessel coronary disease in this patient population, and 8% of them had left main disease. In addition to understanding who was actually included, in some ways equally importantly is understanding who was excluded. So patients that we can't really include under this rubric are patients who had recent ACS, unprotected left main, low ejection fraction, recent or exacerbated heart failure, unacceptable levels of angina despite OMT, and a GFR of less than 30, which was captured in the other cohort. Interesting to know that about 96% of patients in the PC arm alone underwent angiography, which was good. So they were actually moving down that pathway. And only about 80% of them underwent revascularization, but the large majority of them. Interestingly, about 28% of patients, so not a small number of patients in the optimal medical therapy underwent angiography, and 23% of those patients actually underwent revascularization. So again, hard to keep these groups somewhat separate, and important when you're seeing these groups get similar treatments, you can imagine that it will bias you towards no difference. So looking at the endpoints in the ischemia study, we see that over the course of 2 years, and that there's one story that's being told, but as we look out to 4 years, we see that while there's no difference at this at the 2-year endpoint, we start to see that maybe the cumulative incidence of this multi-composite endpoint is favoring an invasive strategy the longer we get out. This is a key portion of this study, and we hope that we're allowed to follow these patients longer term, as maybe we will see a benefit in the longer term. Unlike the general population and the CKD population, no matter how long you follow these patients out, there does not seem to be a benefit to invasive strategy versus an optimal medical therapy. And so you can imagine that CKD kind of dwarfs the effect of anything we do in these patients from a stable ischemic heart disease strategy. So important to note. Additional endpoints, I think when we just look at death from cardiovascular causes or heart attack, again, we see a very similar pattern. So the study showed no significant difference in these patients, but when we look at the actual kind of textured analysis of the curves, we do see that there's a crossover, and maybe over time an invasive strategy will matter, but we can't say that yet. When we look at death alone, it doesn't look like there's a mortality benefit. It looks like most of this kind of, there may be a hard endpoint strategy from MI. Again, this is something that is hypothesis generating. From the data that we have, there's no statistically significant difference, but from the curves, we may see a difference as we start to follow these patients out further. Again, just like the COURAGE study and just like anticipated, revascularization matters for quality of life. It reduces angina more so than medical therapy and faster than medical therapy. Maybe not so much in the CKD arm, which again dwarfs anything else that we do, but in the general population, we see that quality of life tends to be improved with an invasive strategy over a conservative strategy. So again, we're getting reproducible and similar data from COURAGE, from ischemia, and it all makes sense biologically that revascularization seems to matter for that endpoint of quality of life or living better. May not matter early on for the hard endpoint of living longer, but I think the jury is still out as we start to follow these curves out long term. So take-home points in patients who fit ischemia profile and adhere to GDMT, also very important, without acceptable levels of angina. Optimal medical therapy may be reasonable. And if lifestyle limiting angina, there's no significant price to pay and potentially a late benefit to revascularization. So the benefit of stress testing is questionable here. We'll talk a little bit about these data, and coronary CTA really shining here. I think it may be useful in ruling out left main disease, so we know kind of a priori who this study may apply to. In terms of the CKD population, OMT alone seems to be appropriate in stable ischemia, likely sufficient. No reduction in event rates, no relief of angina from revascularization in these patients. And the mortality, surprisingly, at 3 years was about 27%. It's CKD, as we said, is no joke in terms of as a risk factor. Still, questions remain, not because necessarily the study was done in an inappropriate fashion, but because I think we still need to look and delve into these data a little bit further. So what might longer term follow-up show, right? We see these curves are crossing. Is that something that is gonna bear out that maybe there's gonna be a benefit, or are they gonna just come together and cross to show there's no benefit over time? Very important, and I hope the funding comes through to be able to study these patients longer term. Is there equivalence between Cabg, revascularization with Cabg, and PCI? Is there a difference between lesion-based ischemia versus patient-based ischemia? We'll talk a little bit about this. And is maybe adequate for understanding or risk stratifying patients now that we have more sensitive analyses in the form of PET? And are there differences between this idea of procedural MIs that may come and spontaneous MIs, which there's a signal may happen more in conservative therapy over revascularization? And what is this importance of ischemia reduction? We talked a little bit about it, that it seems to correlate with outcomes. And I think when we start looking at the details behind these data, maybe we'll find that the level of ischemia reduction may actually still be a modifier in these patients. So I think the question that I want to focus a little bit about is, how about invasive assessment of ischemia? So FFR or IFR, where do these fit in? And I think this is a big question. I think the question of revascularizing patients based on the ischemic patient versus really fine-tuning and revascularizing the lesion causing ischemia, I think it's very important. If you go in and a patient's ischemic in the anterior wall, but you fix a right coronary artery, you've fixed a coronary lesion in an ischemic patient, but you haven't fixed the ischemia. If you go in and you assess with IFR or FFR that right coronary artery is ischemic and you fix it, it makes sense. It stands to reason that maybe that's actually the strategy by which we're going to improve outcomes. So the FAME2 study, this is a study of ischemic lesions defined by FFR of less than 0.8, who were randomized to PCI and medical therapy versus medical therapy in either single vessel or multi-vessel stable CAD. Exclusions important with any study were MI within a week, left main disease, low EF, prior Cabg, or severe LVH. And again, FFR of less than 0.8 was determined to be significant. When you look at these data, you can see that there tends to be a significant benefit for PCI in reducing the primary outcome of death, MI, or urgent revascularization. The majority of this is urgent revascularization. However, when you look at the data in a little bit more detail here, we see that there may be a trend towards reducing MI, right? We find out that the 95% confidence interval just lands on 1. And so maybe if we follow these patients longer, we could find out that there's a hard endpoint benefit by using this strategy. But the main benefit we're getting is that they're reducing urgent revascularization in this composite endpoint. So many other studies that have really confirmed this finding. Here, FAME2, DENAMI3, compare acute. And when you take all of these data and you put them together, what we do see is that if we follow these patients long enough, actually an FFR or IFR guided strategy of fixing the ischemic lesion may reduce endpoints. It takes a while to see this benefit, so we're not going to see an MI reduction within a year in a patient, but in a young patient or a patient that has survival, it does stand to reason that maybe actually revascularizing this patient will reduce their MI risk, but it's over the long run, not over the short run. So this is 5+ years out where we start to see this benefit in MI reduction by taking a lesion-based strategy, not a patient ischemic-based strategy. So we talked a little bit about FFR. Let's talk about IFR, which is kind of no longer the new kid on the block, but now basically the standard by which we assess this. If we look at IFR as well, multiple studies have shown that IFR may be better than, but at least equivalent to FFR in assessing anatomy, or which anatomy is favorable. So again, the ischemia study looked at the ischemic patient, but I think maybe addressing the ischemic lesion in this subset of patients with stable ischemic heart disease may actually be the kind of tipping point between the difference between these two strategies, and why we're seeing two different results in two different strategies. And now with something kind of hot off the press that came out of the ischemia study, they looked at these patients. So they looked at patients within the moderate to severe ischemia category who had either none to mild, which were very few patients who got through the screening process, but in the moderate to severe category who had moderate ischemia versus severe ischemia. And when you stratify people by the amount of ischemia that they have, this is not the amount of ischemic reduction, but the amount of ischemia they have, it doesn't seem to matter. So people who had severe ischemia by a core lab adjudicated study versus moderate ischemia, we're not seeing a benefit in all-cause mortality, we're not seeing a benefit in myocardial infarction, and we're not seeing a benefit in composite endpoints. So maybe just treating the ischemic patient may not drive reduction in hard endpoints. Unlike that strategy, similar to the FAME2 strategy, when we look at anatomy per se, now this is an FFR or IFR physiology, but just looking at the anatomy, the more significant burden of anatomic disease that one has does correlate with hard endpoints, right? So if you have 3-vessel coronary disease here, your all-cause mortality is higher. If you have moderate disease, it steps down, and the less disease you have, the less likely there's a difference in risk between the two. Same thing reproducible with MI, so it's a sensitivity analysis of sorts, although it's basically a different outcome. But in terms of mortality, in terms of MI, in terms of primary endpoint, in all of these parameters, we see that ischemia may not stratify these patients, so that may not be what we have to look for, but the anatomic findings do. And that becomes important when we start to think about this patient population and we say, oh, I don't see a lot of ischemia on a stress test. Maybe that's actually not the strategy we go to. Maybe the strategy is to define their anatomy and burden of disease, whether that's CT angiography versus coronary angiography, I think is an interesting discussion. So there are studies that are coming up that are going to look more into this kind of lesion-based strategy. FAME3 is one of these strategies that's going to try to differentiate. Can we figure out is this lesion-based strategy helpful for distinguishing between PCI versus Cabg? And ultimately, from the take-home points from all of this discussion, from a revascularization standpoint, remember, coronary angiography should be considered for patients with stable ischemic heart disease whose clinical characteristics and results of non-invasive testing indicate a high likelihood of severe ischemic heart disease when the benefits are deemed to exceed the risk. Now, this is what the guideline is now, but you can easily manage this imagine that this is going to change, because coronary angiography, it's not that that shouldn't be considered anymore based on ischemia, but maybe it should be considered in patients who are worried that have a high anatomic burden of disease and not just the result of non-invasive testing suggesting a high ischemic burden per se. Now, there's no conclusive evidence demonstrating that improved survival, following PCI in patients with stable ischemic disease. So remember, medical management is safe, and therefore deferring revascularization is not associated with worst outcomes in most circumstances. Quantification of ischemia may not be important as we once thought. Remember, the idea of this ischemic burden or the amount of ischemia, there's some older studies, but as we get newer studies, I think we're seeing more and more data that it may not be actually what risk stratifies. But shared decision-making is essential, right? We may not be reducing hard endpoints in the short term. Maybe certain strategies can reduce MI, but it's in the long term. But it is important to reduce symptoms, whether we're reducing hard endpoints or not. So in my opinion, PCI should be IFR driven based on these data. So the importance of lesion assessment and not just patient assessment. PCI these days is a different ballgame, like we talked about. We were really hopeful that maybe we could put stents in that would resorb and there'd be nothing behind, and we don't have to worry about restenosis. We don't have to worry about stent thrombosis. This has basically fallen flat. There may be some data in the periphery, but so far, next generation stents are being investigated still, but there's nothing to suggest that bioresorbable stents are the wave of the future. And they've basically stopped their kind of prime time analyses for this. So, there are different types of stents. I think that this is kind of beyond the scope of this talk, but what we are seeing with newer and novel stents, that the rate of stent thrombosis and drug-eluting stents is very, very low. May vary a little bit, but there really doesn't seem to be a benefit in bare metal stenting versus drug-eluting stenting from a stent thrombosis standpoint anymore. So most of us would argue that drug-eluting stents in most patients should be favored over bare metal stents. And the reason is that there are now data in drug-eluting stents that maybe we can stop their dual antiplatelet therapy. So they would be on a single antiplatelet agent. You would never stop both after a very short period of time in patients with high bleeding risk. So instead of putting a bare metal stent, we put a drug-eluting stent, and now there are data for stopping aspirin after a month. These are the STOP DAPT2 studies suggesting that it appears to be safe to stop aspirin after a month. More data suggesting that maybe Cabg monotherapy at 3 months, and they've had a whole lecture on this, so I won't talk much about this, but single antiplatelet therapy in the high bleeding risk individual with a DES may be safe. There are various calculators that we can use to try to understand at different time points, should we continue DAPT, should we take people off DAPT, and I would recommend using these in your practice. Again, the last topic that we'll talk about before we run out of time is, one of the reasons we think bypass may be superior in certain cases, especially people with significant coronary disease, is that bypass tends to give us a more complete revascularization. And if we incompletely revascularize, whether it's with bypass or with PCI on the left, we see that those patients do worse. So this whole push towards complete revascularization has pushed to the complete trial in other studies. And this has kind of proven this point that in this patient population, that after successful culprit PCI and STEMI, patients were randomized to whether we should revascularize the non-culprit lesions. And it looks like the answer is yes. There were some initial studies that said we should drive this by IFR or FFR. So fix the culprit lesion, IFR, FFR, everything else, and take care of the IFR, FFR positive. Some people suggest based on these data that just take care of the non-culprit lesion by angiography. I think that debate is a little bit more subtle, but the concept is clear that we should revascularize the majority of non-culprit lesions as well as culprit lesions in patients who have STEMI per se. When do we do that? Do we do that in the same hospitalization? Do we do it after? It doesn't seem like it matters. Maybe there's an inflection point at 45 days, but this is probably built into the study. The one place where we don't want to think about complete revascularization are STEMIs with shock, right? These patients are sick, they get more renal failure, they don't do better if you keep them in the lab trying to revascularize them. So take care of the culprit lesion, optimize them fully, don't necessarily bring them back for non-culprit lesions because their shock is going to overwhelm you. And if you try to do too much, they're going to get sick. So take-home points from this part of the talk: newer stents may hold promise for improved outcomes. Yet to be seen what the specifics of that are. Bioresorbable stents tend to be dead for now. Many strategies exist for targeting DAPT, and we've had to talk about that. But defining high-risk bleeding populations is very important to defining optimal and defining how to optimize PCI outcomes. And complete revascularization should be the goal, except in shock. So to finish, medical therapy remains the cornerstone of CAD treatment. Assessing ischemic burden may not be relevant for revascularization, but treating the ischemic lesion versus the ischemic patient may end up being the strategy that we take going forward. PCI has a lot of improvements that have improved the field. DAPT duration may be tailored now that we have data for longer-term DAPT, shorter-term DAPT, depending on the patient population. Complete revascularization improves outcomes. Some things that we didn't get to today in terms of the bypass realm of things. We talked a little bit about diabetic patients. Cabg with multivessel disease, Cabg seems to be superior. With left main disease, I think there's debate, but PCI would be a reasonable option. And in the long run, for ischemic cardiomyopathies, Cabg seems preferable to medical therapy. And finally, to help us really understand what are the best options between medicine, between medicate, dilate, operate, I think these, working together in teams, primary cardiologists, interventional cardiologists, imaging, cardiac surgeons are important to optimize decision-making between all of these categories. So thank you very much for your time, and I really appreciate the chance to be part of these sessions.